As healthcare moves away from traditional fee-for-service models, providers need a strategy to stay competitive. That's where Strategic Healthcare Partners comes in. We offer expert consulting and ongoing management oversight for providers looking to form an accountable care organization. From financial feasibility analysis to helping you choose the right ACO in a crowded market, SHP provides the clarity you need to make informed decisions and transition to value-based care. Learn more at shpllc.com.
Welcome to Beyond the Stethoscope Vital Conversations with SHP. As we take our summer break to prepare for Season 5, we are revisiting some of our most impactful episodes. In this Season 4 episode, Tom Campanella from Baldwin Wallace University joined us to discuss the critical issues facing primary care. With over 40 years in healthcare, Tom addresses the shortage of primary care physicians and the economic challenges that undervalue this essential field. Despite the U.S. spending nearly 20% of its GDP on healthcare, primary care remains underfunded, a gap that's beginning to see overdue recognition through innovative approaches. Tom explores how value-based care is affecting primary care compensation and the broader economic and political factors at play. He also highlights the role of technology and telehealth in improving access, especially in rural areas, and discusses the efforts of retailers like Walmart and Walgreens to expand healthcare access. If you enjoyed this episode, please rate and share our podcast in your favorite podcast app. It really helps the show. Thank you for tuning in. Let's dive back into our vital conversation with Tom Campanella.
Welcome to everybody, and thanks for joining us.
Thank you, and I really enjoy the company that I will be having over the next half hour or so.
Yeah, we are really excited to have you here, Tom. I know Mike cleared his schedule specifically to join us, so it's kind of a treat we have Mike on here with us as well.
Absolutely. Looking forward to the discussion. I really like the kind of the high-level philosophical parts of it. So let's get going.
Sounds great.
So Tom, you've, especially in the academia world, you've covered so many different topics. You've studied, you've got data come from all direction that we've read, and particularly you've done a lot recently in the primary care space. And we obviously work a lot of primary care physicians. We thought we'd start there, and just really want to hear your thoughts and things you've come across regarding various primary care shortages, the other challenges and trends you're seeing. Here we are halfway through 2024. So get our audience up to speed on what you've been seeing and things that you see coming on the horizon on the primary care space.
Thank you, Jason. But I want to start off just briefly. While I've been in academia for the last 20 some years, in total, I really have 40 years worth of experience in healthcare in all sectors. So both the payer side, also as an associate dean of a medical school, osteopathic, which was primarily focused on family medicine, and was situated in rural Appalachia, Ohio, down in Southeast Ohio. I was on the payer side as a VP of healthcare finance for a Blue Cross plan, healthcare attorney, healthcare consultant, economist, a little bit of everything. So what I try to do in all my writings, podcasts, and that, a lot of it is obviously based on what's happening in the current world, but a lot of it is based on my own personal experience over the last 40 years from different perspectives. And that really dovetails into the subject of family medicine, because as I said, as the associate dean of Ohio University's osteopathic medical school, which primarily focused on family medicine. In fact, this was the late 90s. We produced more family medicine physicians than any other medical school in the country from a percentage standpoint. But it was also in a rural area. I gained both an appreciation of the value and the importance of family medicine and primary care, but also the challenges in rural America, which I know we're going to be talking about later. The bottom line, when you talk about family medicine, when push comes to shove, it is probably one of the most ironic and maybe frustrating and challenging subjects, because as everyone knows, we spend more on healthcare than any other country in the world, close to 20% of our gross domestic product. And the specialty that is focused on keeping people healthy, we approximately spend about 7% of our healthcare spend on family medicine and primary care. So we really have it backwards. And really, that's the reason why when we talk about healthcare, we really have a sick care system that really treats people, and most of our dollars are focused on after somebody is sick, has a health issue and that, rather than preemptively focusing on trying to keep them healthy, which is the ultimate focus of primary care and family medicine.
Have you seen that start to shift recently? It kind of feels like in our world that we're a little bit late to the game in this section of the country, but nonetheless, it does feel like that the boat is beginning to turn. What is your experience?
Yes, I definitely see it moving in what I would call the right direction, but at the same time, it needs to be done in a much more accelerated way. I think what's happening is, and we know this, and this is a subject in itself, all the disruption that's occurring in healthcare with all the different players coming from all different ways. I think that's opening up opportunities for different players, including health insurance companies, analytical companies, and that to sort of partner, hire, come up with creative collaborations with family medicine and primary care, which is then creating more opportunities for family medicine and primary care, and hopefully is incenting the medical students to go in that direction, which is really should be the long-term goal. But I've had the opportunity to I speak on a number of different topics, different audiences, but one of the most interesting is I actually speak to medical students and family medicine residency programs in different parts of the country. And I'm starting to see a little bit more steam, a little bit more hope, but we still got to pay them so much more money than with the value that they can and are providing versus what we pay them versus other specialties is really basically a crime. And then the other thing is the burden we put on primary care physicians ultimately is causing a lot of burnout. So at one end, we're starting to get more in, but the other big challenge, Mike, is we have a lot of physicians that are in family medicine primary care that are in their 60s and they'll be retiring. So we really got to ramp it up. We talk about World War II analogies, especially with D-Day and that, and we really need a Marshall Plan, as they did in Germany and everything else, for primary care and, from a country standpoint. So that's where I'm at. So we're going in the right direction, but it needs to be accelerated big time.
So Tom, kind of going back to the point you raised about needing to be more proactive versus reactive in the sort of care that we're giving, that seems to me to be more of a cultural problem rather than one that we can throw dollars at. How do you think we could overcome that?
Well, it's really a couple things, Aaron, is, the culture aspect is bluntly, we have to change the mindset in the US to get individuals much more engaged in their own health. Because when we compare ourselves to other countries, one of the reasons why we may not have the best outcomes is bad lifestyles and other types of things. And we need to get them more engaged in their health. That's where, again, I really think having family medicine and primary care much more robust, including with their staff and using technology in that, can be a way to educate and engage the patient in their own care much more than it is today. And maybe from a family standpoint, especially when you're talking about seniors and others, getting them much more involved in that individual's care, or, you know, getting on top of them and whatever's needed. But there is a lot of that going. The other part of it is, let's face it, when we talk about 20% of our gross domestic product being spent on healthcare, we may perceive that as a cost, but a lot of stakeholders are looking at that as revenue and profit. So they make a lot of money on our current sick care system that bluntly devalues primary care. So part of the challenge we have, even in Washington, D.C., is politically, is that a lot of these players are in effect, you know, you won't see them out in the public, but behind the scenes, these lobbyists and everything else are protecting their little piece of the pie, really big piece of the pie, to the detriment of primary care. So that's when you say, why can't we do more? This is so obvious. I mean, you could put a bunch of high school students together and they can come to the conclusion of what needs to be done. But, you know, as you know, the name of the game is follow the dollars. And there's a lot of dollars being spent on, you know, once a person is sick. And I hate to say it, it sounds terrible, but that's an issue culturally, from a societal standpoint, we need to address.
It does seem like, at least to a small degree, that as the value-based component has become a bit larger, that's driven up primary care providers' salaries to a certain degree. Like I feel like I'm sensing in our market that if you wanted to recruit primary care to a rural market 5 years ago, even 10 years ago for sure, they're going to be employed by the local hospital because they can't make it on their own individually. And with some movement of value-based care, somewhat successful versions of it out there, it's driven up the compensation for primary care to a certain degree. Are you seeing that nationally? And is there any sort of leverageable part of that that can be replicated that is a larger solution than just market by market?
Well, first of all, I am seeing that nationally, Mike, and it's back to, you know, what we learned in school, supply and demand. And right now we have that limited supply of primary care docs, but there's a recognition in a value-based world that we're trying to transition to, with multiple stakeholders, including for-profit and nonprofit, getting involved, is as you get more players, bluntly, the family medicine physician has more leverage. They do have options. And as you know, in the non-healthcare world, when you have options, you know, you're in a position where you have the ability maybe to control and demand higher compensation, a better quality of life, that type of thing. So I definitely see that coming. And it is starting to come in different areas of the country to different degrees, you know, not just regionally, but urban, rural, and everything else. There's obviously a lot of other factors. You can't look at it, you know, analogy that we talked about earlier, Mike, really applies to family medicine as well as other subjects in healthcare. I look at it like a piece of a puzzle. You can focus on one piece, say family medicine shortage, what can be done. But if you just isolate just on that piece and your knowledge base is just focused on that piece, you're never going to really understand the challenges, but more importantly, find the answers. You got to look at all those other pieces that sort of come together. So you got to have a better understanding of what's happening in the payer world, the hospital world, overall state and national health policy, the different types of payment methodologies, what's happening in for-profit. So you have to have that appreciation. But just like a puzzle, once you have that grasp of that, you're in a better position to both locally and regionally and nationally, going back to your pilot programs and that, to put pieces together and say, hey, I think we found a solution if we put this piece together with that piece and everything else with these stakeholders, state or whatever else involved in it, getting the payer side, whatever it happens to be. but each region, including urban, rural, region of the state or whatever, is not necessarily have the same solution. What makes sense in Montana may not make sense in New York City, obviously. We went through this with COVID and everything else. You just can't have across the board thing. There's issues going on in each region. So there really needs to be almost like a ground up approach too, a national approach, but a ground up approach to address some of the challenges in family medicine and primary care.
Let's take a quick break. We'll be back in just a moment.
Did you know SHP provides cradle-to-grave managed care contracting services? SHP offers comprehensive managed care contracting services, from contract language review to reimbursement rate analysis. We address charge level, clinical coding, billing, and appeals to optimize overall reimbursement. Don't let aging contracts hinder new services or locations. Be proactive with SHP Managed Care Contracting. Visit shpllc.com for details.
Tom, you mentioned a couple of things I'd like to follow up on. One, in terms of the provider base, you've got the aging population that you mentioned before, and then the younger group that's coming up and maybe not filling that gap number-wise or pay-wise. Then you also mentioned technology. Aaron and I have talked about a few different topics that kind of maybe fits in that vein in terms of provider gaps that exist, right? And from the provider side, you've got utilization perhaps of mid-levels that haven't been utilized as much as they could. Or in particular, last year, we've talked a lot about retailers, right? Whether it's the Walmarts, Walgreens, Dollar General even, that at least are a little bit more in the accessibility space than anything else. Then on the IT, you've got telehealth that really took off from COVID. And of course, AI, that's really been a hot topic.
Mm-hmm.
I'm curious, I know I just threw a few different kind of things at you there, but those items, whether it's the provider side like mid-levels or the IT side like telehealth, how they may be of some benefit to this gap that exists over these coming years, or maybe what you're seeing nationally that maybe those can provide a relief to that gap.
Well, I definitely think, just like it would in other areas, the effective use of technology can allow things to become more efficient, to be able to do things in a sort of more focused and productive way. Let's talk about telehealth for an example. Telehealth has been, was really starting to ramp up prior to COVID. Obviously, COVID accelerated it big time. I actually wrote an article, a blog, back in 2018, which was obviously 2 years before COVID really hit, about, I called it care in the home setting, the new frontier of healthcare. And I saw that trend, which now everyone's talking about hospitals at home or whatever. But I wrote what I thought was a reasonably good analytical reason, going back to the pieces of the puzzle, how the different factors that resulted in maybe care in the home setting playing a key part. Ultimately, just as an aside, and that will fit into this discussion, is that, I knew the payer side, both the government and commercial and employers and self-insured employers were trying to drive healthcare costs, especially because escalating to the lowest cost setting, but it needed to be a safe setting. And the number two thing is I also recognized that what was happening in the hospital world, which also results in why we have a lot of competitors, is this trend again has been occurring for a number of years prior to COVID, is inpatient admissions across the board have been going down throughout the country on the hospital side. But what's happening is the ones that are going into the hospital have more high risk factors. So in many ways in hospitals, it's especially in major urban areas, are almost becoming like giant ICUs, intensive care units, because it's really focused on a high risk. Where are these patients then going? Well, they're going to the outpatient world, which we've been seeing that for a number of years, but that's accelerating. And by the way, this is a challenge for hospital, because on the inpatient side, when you think about it, how many competitors do they have? Just a few other hospitals. But on the outpatient side, you could have niche players, big players, whatever it is, regional, national players. But then when you think about the lowest cost setting, I was thinking, God, care in the home setting. But to do that, it's a chicken and egg phenomena. You can't have care in the home setting from a safety standpoint unless you have the ability to be able to provide it. You need technology, you need medical device and everything to both provide it, to both monitor it, diagnose it, and everything in that home setting. But where the chicken and egg comes in, think about it. If you're a technology company, if you're into virtual care, if you happen to be a medical device company, you're not in it because, I hate to say it, altruistically, you're there to make money. You have research and invest in it. So the only way you're going to pay for it is if you know there's a long-term trend that payers are going to pay for it. So that's where the synergy comes in, the chicken and the egg. Payers are saying, we want to drive it to the lowest cost setting and we're willing, but it's got to be safe. And then at the same time, medical device technology, including telehealth, is saying, we're willing to do this and invest in it to make it user friendly, but we got to have a long-term revenue source for it. So you got that synergy occurring. So telehealth, what's so great about that is not only is it the ability to be able to do it within a home setting, for an example, but also, which we really haven't done enough of, we talked about patient engagement and those types of things, using telehealth with people like nurse practitioners, PAs, and could be cancer educators, and using telehealth after the visit or between visits to better engage that patient plus their family members into whatever health issues, chronic health issues that are having, can be a great vehicle to be able to, sort of find a way to keep people healthy and everything else. So there is a lot of that advancement. Where the challenge is one of the, topics that, I find really important is rural healthcare, which you're very familiar with. And, when you talk about broadband and other areas, that's where you have a potential opportunity with telehealth, but depending on the rural area, you may not have access to it, or the people may not be able to afford, the technology costs or whatever it happens to be, or they may not have, they may have issues just being able to grasp, the ability to be able to use technology in a more effective way. So you got to also be able to address that. The good news there, as an aside, is just last year, there were billions of dollars set aside for a broadband expansion throughout the country, with the major focus being in rural arenas. So there is a recognition. So hopefully that will allow that vehicle to become even more important. And I definitely think nurse practitioners, PAs, all these other ones can be a great vehicle to help complement the primary care family medicine physician in those environments.
Tom, I get that my next question is going to admittedly come across from a very biased, we represent nothing but providers point of view. However, in that whole discussion that you were just having, what I find is one of the issues that we always run into is that the business case from the perspective of the local provider in the rural market is tough to get in telehealth because of the lack of payer support for it. And in a lot of ways, we sense that the payers are less creative, maybe less incentivized. I don't know what the answer is to fully support that that tenet that we're going to move into the lowest cost setting, and that becomes more of a barrier than anything. Again, we see the world from a very, very small lens, but what's your perspective around that? Have you sensed that, or are payers across the country more receptive and more supportive and facilitating that deeper in other places?
Well, I think, Mike, like anything else, it's hard to make across the board generalization because it depends on the payer, it depends on the region, those types of things. I see them being at least verbally, and this is always the challenge, what you say and what you do, and verbally supporting expansion of telehealth, verbally supporting any initiative that addresses social determinants of health, those types of things. The question is, what they are actually doing about it? I think with Medicaid and managed care and some of the Medicare Advantage plans, they are, even through federal and state legislation and rules and policy, are really, there's really putting more pressure on them to get more involved in things like telehealth, addressing social determinants, really finding ways to sort of address whatever barriers there are to provide better health care, from that standpoint. They always say it takes a village or whatever, but, if you're talking about rural areas and you're talking about smaller providers, you cannot, we do business plans and everything else in the academic world. As you said, if you really did a dollar and cents return on investment type situation with some of these rural hospitals, for example, you're just not getting that return on investment because you don't have enough people. The specialties in that. Can you keep an ER open when you only have X number of people? How do you handle and pay for specialists or others if there's travel issues in that? So that's where it really does have to be. That's why I mentioned things like Marshall Plan, not just for family medicine, but even things like rural health care. That's where, you got to get employers involved. You got to get the government involved at state and level and the federal level. There definitely needs to be additional compensation. What I didn't like, bluntly, is, for an example, the COVID part. There was, and I know there's a lot of issues politically, and I'm not going to go into that, but when it came down to giving money out to different players after COVID hit, and there was money given to hospitals, for an example, but a big share of that money went to the big major hospital systems in the big urban areas. And from my standpoint, that they shouldn't have gotten it. They have the ability to survive through that thing. What was not done is they should have been narrowly focused on those small hospitals, those rural hospitals. That's where the money was. COVID hit the rural areas more than the urban areas. And I'm not saying that there wasn't challenges in the inner city and because of COVID, but the point is we should have been directing it to there. Problem is the small rural hospitals don't have the political lobbying force, even with the American Hospital Association, than the big urban centers. So that's part of the challenge that you have there. And so it really needs to be coming from different sources. Employers, especially self-insured employers, are a key, but where the challenge is, as you guys also know, is that one of the challenges, including after COVID, there's been an erosion of employment opportunities in rural areas, which is one of the reasons why we have so many challenges there. So it's not like we can say, okay, employers, you need to help subsidize this telehealth, or you need to financially support that rural hospital, the small hospital, and that a lot of them are leaving. And that's where I think, even with the big urban hospitals, I think there should be some form of, I'm not a big believer in tax, but the bottom line, they need to be help support, we're one America, and it's not like we focus just on one sector. We need to recognize that rural America is part of the United States, and we need to address it. And I don't care if you live in an urban area or whatever, or a major player in the urban, including an employer or whatever, there needs to be some form of financial support for providers in our rural parts of the country. And I grew up in the inner city of Cleveland, so it's not like I'm a small town rural guy and I don't care about it. But, the bottom line I saw, and I continue to see in my talks and in my visits in rural America, It's not just healthcare, it's a quality of life issue.
Instead of the Marshall
Accommodation.
Plan, we need the Campanella Plan for tackling this.
Yeah. Hey, actually, it's funny, way back when in my 20s, I was a Cleveland City Councilman, and I quickly discovered that even though I was altruistic, passionate, and everything else, it was the political side was not me. I played a lot of sports, and I had so many times people coming up to me in politics, you got to play ball. Or I knew I was not meant for politics when I was starting to tell my mother, and she would ask for help, and I'd say, well, what's in it for me? So I'd rather, when I write and publish, or speak, I never know, am I doing it from an educational standpoint or a venting standpoint? Because, it really is frustrating to see, this country and what we spend on healthcare, and to have some of the discrepancies as we talk about. So on a personal basis, I'm 74 and I don't plan on giving up. And I plan on, God willing, being involved in one way or another in healthcare advocacy and policy on things like family medicine and rural healthcare for hopefully many, many years.
We'll be right back.
IPAs, Independent Physician Associations, unite independent providers, creating a collective voice in an evolving healthcare landscape. By joining forces, they negotiate better rates and fair contracts. SHP manages comprehensive IPA services from contracting to practice enhancement and education for our members. Visit shpllc.com for details.
So all government help and Marshall Plan, Campanella Plan aside, what successful models are you seeing rural healthcare where they are, local providers, local health systems, whatever, have stepped up and are, taking innovative approaches? What are those things? What does the right direction look like from a rural provider's world now? Forget the cavalry running in to help. What are they doing themselves?
Well, first of all, as they always say, God says you got to help yourself first. So in other words, the community needs to be involved, and they need to be a catalyst for a lot of this. And just as an aside, again, back to personal experience, back in the 90s in Southeast Ohio, 9 counties, you talk about a very rural area, some of the poorest areas, not only in the state, but in the country. I got elected, besides the role of associate dean and doing population health, I was over a collaborative of different stakeholders that were working together to address the type of issues we're talking about in that region of the country. So for an example, in my role, I was in a position where I had access to mobile healthcare clinics back in the 90s. They actually reported under me as part of the medical school role. So we were out there in the communities, but we also worked with the Department of Health, Jobs and Family Services, the local hospital, the different types of the school system, because healthcare starts, in grade school, in different ways. And we basically said, we are all back to the puzzle, play a certain role within this region, but we're doing it in silos. We need to work together. We need to actually put together a collaborative to work together. And then we looked at getting funding from Robert Wood Johnson to help out, from that standpoint, the state and everything else. We were addressing issues like licensed schools, which was a major cause of absenteeism, for an example. But we had to come at it from different direction. Where I'm laying that foundation is I saw the potential back in the 90s and what I'm starting to see in different parts of the country. And I don't have them all in front of me, but you could actually Google to find out. But like in the state of Washington, for an example, and others, they have collaboratives that are working a similar type of perspective where you get local players taking ownership. And that would include the employer side too, obviously, and the local hospital working together finding ways to do things in a much more efficient way, but identifying and prioritizing the major issues and then coming at it together. You can imagine if it's a collaborative, you have politically and everything else also more leverage with the local politicians, but also within the state capitol, and then hopefully finding ways to be able to get the congressmen and senators involved in doing things. So that, I think, is sort of the ground up approach in it. You got to have leaders in the community taking ownership, not just recognizing that we just can't have our hand out. The good news is I always found, including in my own experience, people from small communities don't have the attitude of looking for handouts. I think most of them, from what my experience was, that they really, if anything, had issues with that and wanted to take things on their own. So I think there is that motivation they may need, and we're starting to see this. The federal government is working and they have planning grants, for an example, which I think is great. So for an example, you may have a community in Georgia or wherever, and they're wanting to do this, but there's infrastructure issues or technology, or how do we get these players to work better together? There are federal grants available that might be able to help with some of the backroom stuff to allow this collaboration, so that when they're working on a family, say, you got to worry about HIPAA, the privacy stuff. But if you're working on an area that there's issues, in or something like that, but multiple agencies are involved in it, it might even be with the same family or that, there should be a linkage of information and data to have more of a comprehensive approach. So I think the collaborative approach with assistance from the state and federal government and others is, I think, is an effective way to be able to have that ground up approach.
So you're talking about changes to HIPAA potentially as a part of this. And I agree with you. I've been the HIPAA wonk for most of the organizations I've worked for in the last 20 years. And it's both a barrier and a protector. So I guess maybe expand on that a little bit. I'd be curious to hear how you would see that sort of change play out, because I think you're right. It's one of those things that's potentially hindering care.
Well, I remember I was teaching a class, I was in health economics when the HIPAA laws came out. And one of the problems we have is like a pendulum. We have an issue and we go all the way to one direction or all the way to the other direction instead of finding the right direction. It's almost like we work off of, polls, who's, it's a political arena, let's face it. So, the whole idea of HIPAA obviously is protecting the individual's privacy from a healthcare standpoint. On the other hand, in protecting that, it ultimately is an inhibitor of communication between providers. COVID was a perfect example where in communities, urban and rural, for an example, you may have people that had multiple health issues, seeing multiple different providers, including mental health providers. And they may also be in a position where they're going to local community health centers or whatever. And then we're trying to address initiatives and identify these people and determine what's best we can do, both individually and as a group. But if the players can't communicate with each other because HIPAA is a barrier, then that's where it gets really challenging. But it needs to can't be administrative burdensome, but some type of release on a more general basis that allows for this type of communication and education, from that standpoint. And while at one end, maybe it should be individual, on the other hand, that could be really bogged down. There just needs to be that fine line. And I think if you got the right people in the room that understand the issues, solutions can be done. It's just a matter of just bringing them up to the table, from that standpoint.
I'd be curious, you've touched on both kind of a cultural mindset in rural community, but also some legislative action that could be taken. We've had REH here recently, Rural Emergency Hospital. Hopefully I got the acronym right. That's taken effect, but we've seen a slow adoption of that for various reasons. 340B, swing bed program, having that thing. And of course, those are big hindrances to a rural hospital being able to take that on. Do you feel such legislation is one, a big piece of the puzzle you were just talking about, and two, removing those little pieces like 340B may just further adopt such a model that would be acceptable to the communities in those rural hospital settings?
Well, first of all, this goes back to my argument before in regards to the COVID, quote, bailouts to the hospitals, for an example, where it should have been going to the small hospitals, the rural hospitals, and a big chunk of it went to the very profitable major urban hospitals. Well, it's the same thing with 340B. I mean, the whole theory behind that was, to be in a position to be able to target, individuals and hospitals that are providing care to, in effect, the people that really need it, the poorer people, the uninsured, those types of things. And next thing you know, every hospital in the world is getting a chunk of 340B, and then they're upcharging it and everything else. That should be narrowly focused on certain hospitals, especially small urban rural hospitals, from that standpoint. And that's an example of redirecting resources for the right reason, from that standpoint. So, and then the whole idea of emergency hospitals and, ultimately focusing on that, as well as, the effective use of different for-profit players that are out there. Walmart's been in healthcare. Now I don't know what's going on with them because they were in, then they're out, who knows. But you mentioned Dollar General, for an example. Dollar General actually has, I know they experimented in Tennessee, mobile health vans, and in which they were putting on their sites and others, be able to address it and hopefully go out to the communities too. And I know Dollar General's like all over the place in rural America. And, there may need to be, more involvement with players like that there to be able to address it. In regards to the different models, like anything else, it's not one size fits all. I mean, there's pros and cons, and the devil's in the detail in regards to some of the options that they're throwing out there, including the emergency type hospital settings and that. And I'm still in the process of evaluating some of these things. So I'm not in a position to really get that specific.
Thank you for joining us today. Boy, it feels like we just barely scratched the surface. We would love to have you back. I think there's a whole lot more to talk about and be able to pick your brains some more. And I guess I'll speak on behalf of Jason and Mike. We really enjoyed today's conversation. So thank you for joining us.
Thank you. And I really enjoyed this. And as you can tell, I'm not short of words, but hopefully they're impactful. But feel free to reach out to me on multiple topics. I enjoy talking about it. And, and hopefully we can continue this relationship.
Yeah. And where can our audience find you if they want to reach out?
Probably the easiest. Well, first of all, definitely reach out on LinkedIn. And so under Thomas or Tom Campanella. And that's where all my publications are posted, actually, including podcasts. Hopefully, we can work it out where this podcast, I can post it on my LinkedIn page too. And I actually have a monthly healthcare recap, which I hopefully will have the links from this podcast to send it to about 9,000 people too. And so that is the one way. The other way is, strictly by email. It's real simple, tcamp, TCA, M as in Mary, P as in Paul, at B as in boy, W as in Wally.edu. So that's my email address, tcamp@bw.edu.
Okay. Alrighty. Well, thank you for tuning in today, and we look forward to having you back.
Okay. Thanks, guys. Appreciate it.
This has been an episode of Beyond the Stethoscope, Vital Conversations with SHP. If you enjoyed this podcast, please be sure to rate and share it with your friends. It sure helps the show.
Production and editing by Nala Weed. Social media by Jeremy Miller.
And our co-hosts are me, Aaron C. Higgins, and Jason Crosby. Our show producers are Mike Scribner and John Crew.
Thank you for listening, and we'll see you next time. Aaron and I like to always save the best question, the hardest question for last. And
Oh, thanks.
yeah. But given where you're located, I think I already know the answer. It's a popular recent debate. Who really is the GOAT? Is it LeBron or Jordan? Or a write-in vote?
Oh, I'll tell you. Yeah, it's a matter of perspective. Obviously, from a Cleveland standpoint, it's also a matter of perspective. We had one perspective of LeBron in 2016 when we won, and another one when he moved to Miami. So that perspective changes a lot too. But and I have to admit, Jordan, being a Cavs fan in the 90s, we had an unbelievable team during that period with Mark Price and Doherty and Nance and those guys. But that Jordan, so many times prevented us from going. And just a quick story, by the way, I was actually in Chicago at a sports bar in the 90s when we lost to Chicago, when the shot they keep talking about. And, and I was in a bar and I was giving all the Chicago fans a hard time because we beat the Bulls 6 times during the regular season. And then the shot comes along and everybody forgets those 6 games. And if I hear that word, the shot, one more time, or the drive or the fumble or whatever, come on, guys, give me a break.
all know he pushed off, though. It was an offensive foul. What are we doing?
Yeah, right. Tell me about
Call the foul, ref.
Oh, Tom,
Yeah,
it was hard to be a Cleveland fan, period, during the 90s.
Oh.
All the heartbreak.
I love that you brought up the fumble. That's a great.
Yeah, don't go there. I brought it up, so mea culpa.
You already know that understanding your data is key to improving patient outcomes and financial performance. But how? At Strategic Healthcare Partners, our analytics services help turn your EMR and other data sources into actionable insights. From identifying areas for improvement to guiding you through implementing changes, SHP supports you every step of the way. Our performance analytics service dives even deeper, providing custom reports that help you stay ahead in the transition to value-based care. Unlock your data's full potential with SHP. Learn more at shpllc.com.